you, Dr. Swaminathan, for joining us. It's an honor, a privilege. Can everybody hear me? Seema, can you hear me?
Yes, I can hear you.
Dr.
Hi, Dr.
Swaminathan,
Swaminathan.
can you hear me?
Hi.
Thank you
Yes.
so much. It's an honor. It's a privilege for all the RP members to have you on board and to give us share some of your wisdom today. Dr. Soumya Swaminathan is an Indian pediatrician and a clinical scientist known for her research on tuberculosis. Dr. Swaminathan has been chief of the World Health Organization since March 2019. Previously, from October 2017 to March 2019, she was the Deputy Director General of DDP at the World Health Organization. Dr. Swaminathan was born in Chennai, India, and is the daughter of Indian father of Green Revolution, Mr. M.S. Swaminathan, and Indian educationalist Meena Swaminathan. Dr. Swaminathan holds MBBS from Armed Force Medical Colleges in India and MD from All India Institute of Medical Sciences. As you know, these both are the premier institutes in India, along with a diplomat of National Board from the National Board of Examinations. She subsequently held postdoctoral medical fellowships in pediatric pulmonology at the Children's Hospital, Los Angeles, California, Keck School of Medicine at the University of Southern California. Thank you, Dr. Swaminathan, for joining us.
Thank you. Thank you very much, Dr. Reddy, Dr. Suresh Reddy, and Dr. B.K. Kishore for this invitation. And it's a pleasure to be with the API this evening. I'm speaking to you from Geneva, which is the headquarters of the World Health Organization. And as Dr. Reddy just mentioned, I arrived here at the end of 2017 as a Deputy Director General to the new DG at that time, Dr. Tedros, who had just taken over. And then last year we had what we call a transformation of the organization. And I moved into this role of Chief Scientist, which is it's a new role that was created at the organization and a new division of science that was created. So it's really very exciting to be the first Chief Scientist of the WHO. My background is in tuberculosis research and TB and HIV research, though I'm a pediatrician by training. And I found that being in this, literally it's like a hot seat, you know, at this time when probably a once in a century event, this pandemic. I don't think any of us would have ever imagined that we could be in this situation that we are in today. It's strange because pandemics have been predicted. We've had pandemics in the past. They've been mostly, or almost all of them have been influenza pandemics. And it was always believed that there would be viral disease, most likely a viral disease one day, most likely zoonotic, that would cross over from the animal to the human species and then spread through the respiratory route. And many of you must have seen the film Contagion. That was, of course, made after SARS. And it was in fact filmed at the WHO headquarters here. One of our doctors actually died in Hong Kong. He was one of the first people to identify and work with the SARS patients. Now this coronavirus, we heard about this on the 31st of December when China actually reported a series of atypical pneumonia cases. And at that time, very quickly, the WHO has, through its network of emergency operation centers in every country, through the International Health Regulations, which is a regulation that's been formulated, that was last updated in 2005, essentially because all member states of WHO, we have 194 member states, came together and formulated these rules, essentially to provide information on diseases which may be occurring within their borders, but which may have international ramifications, and also undertake to do a series of things like improving surveillance, improving reporting, improving preparation for response, and then undertaking a periodic evaluation. Now, what this pandemic has shown is that no country was prepared enough for something like this, even though every country has done mock exercises. The United States used to have a pandemic preparedness cell, I think, within the White House itself. There have been several reports, there have been several exercises, simulations. But when it actually happened, I think even high-income countries, which have very high resources, very good health facilities, have been affected, as we see what is happening now in the US, and before that in many countries in Europe. And essentially, we see that those countries, even the low-income countries where public health infrastructure was maintained by the government, or there has been investment into public health infrastructure, primary health care, they are the ones who are able to keep it under check. And good examples are in our region, Southeast Asia region. You have Thailand. They were one of the first, in fact, they were the first country to get a case from China. And the Thai lady physician at the University Hospital in Bangkok was the second person to sequence the virus after the Chinese scientists, very early in January. So the Chinese put up their genetic sequence data on the 12th of January in a public database called GISAID. And the Thai lady also reported it almost on the same day or a day later. And that's when we knew it was a coronavirus. But coming back to countries like Vietnam, low-income country, but with an excellent primary healthcare infrastructure. And within India, you see the state of Kerala, which has a long history of having invested in both education and health, and a decentralized system of management. They are the ones who are able to cope with this disease. I have been in Thailand. I spent 10 days there in 2018, traveling in the rural areas, and I was so impressed to see the network of primary health centers, and below that, right down to the village level, the community level. And the kind of committed health workers they have, the kind of infrastructure they've been able to build. I saw patients undergoing peritoneal dialysis, living in a very simple house, a hut almost, farmer, but undergoing peritoneal dialysis and having high quality of care for 6 years, looked after by his wife and daughter who had been trained on peritoneal dialysis. So I think this is where countries like in Europe also fell short, because they did not have the workforce, the public health workforce, to be able to immediately go identify these cases, isolate them, do the contact tracing, quarantining, follow up, reporting. You know, these are things you need a workforce. And now we're in a situation where many countries are quickly trying to hire what they call contact tracers. And I was reading that in the United States, it's estimated that you might need about 300,000 contact tracers. And currently, I think the CDC says you have maybe less than 30,000, 28,000, something like that. So there's need for urgent investment in public health, in preparedness, in surveillance, and most important, in primary health care, which is where the health system starts interacting with the community and building up that trust, building up that relationship, getting to know the community, understanding the disease burden, and focusing on prevention, not just on disease, on treatment. So when we formulated our 5-year strategic plan, we actually had what we call the triple billion goals. The first billion was providing universal health coverage for 1 billion more people within the next 5 years, that's up to 2023. The second billion was about protecting another 1 billion people from outbreaks and emergencies. And then the third billion was the billion on healthy lives and well-being. So focusing on the social determinants of health, the risk factors for health, like tobacco, like air pollution, like water sanitation and nutrition, road safety, and also mental health. These are all determinants of health which governments do not often invest in, especially in developing world. And so you get then a system where you're basically focusing on tertiary health care and forgetting that investments in prevention and attention to these determinants could actually give you much more bang for the buck. Perhaps I would like to say a little bit about the science division and what we've been doing, particularly in this pandemic. And then I will open up to questions. It might be more interesting for you to actually ask me questions rather than me going on giving a talk. So I'll just say a little bit more about science and why it's so important. Now, obviously, I think people have realized, and the general public appreciation of science, I think today is much more than it has been in the past, because they see in the front pages of their newspapers every day, anywhere you live in the world, any TV channel you open, it talks about some new finding of COVID. And very often it's a finding which is not even in the peer-reviewed literature. It's just a preprint that somebody has put up, but it's appealing to the journalists who then put it out there. So there's perhaps a better understanding, but perhaps also a questioning of science. And how can things change so much? How can scientists, contradict each other? How do their recommendations change? So I keep explaining to journalists and to public, how guidelines are made, how evidence is created, how meta-analysis is done and synthesis of evidence is done. So one of the things, of course, WHO does is providing the normative guidance, the standards, the recommendations, both clinical and public health recommendations. And those are done through a process, a very well-controlled process, obviously, of having a guideline development group that looks at the evidence and grades it and so on, and has to be free of all conflicts of interest, etc. So we have a good process to set up these committees and get them to do the work. Now, in an emergency, you have to do it super fast, because normally this takes a few months of time to develop a guideline. But here, within hours and days, we have to turn around without losing the scientific rigor that goes into it. So that's where the science division has come in, and working closely with the emergencies division. We pick up the topics which are important, and then we look at how to do the guidelines in a way that's rapid and yet is as evidence-based and as robust as possible. And of course, we keep updating these guidelines, and we get questioned all the time. We get challenged all the time. We've been challenged on our mask guidance, on how this disease transmits, on antibody testing, on schools opening, so many topics which are very difficult. And so one of the things we keep saying is we need to be humble, because we're learning about this virus, and every time we think we understand, there's a better paper that comes out, or the virus does something new that we had not predicted. But what is clear is that this virus will continue to spread as long as there are susceptible people in the population. And from the surveys that have been done so far, the antibody surveys, we have almost 90 or so surveys that are going on in countries. We have data from about 30, 35 of them. And they all show that on average, about 5 to 10% of the population of those places are antibody positive. So whether you take London, or you take Northern Italy, or you take places in Germany, the one exception seems to be New York City, where the antibody prevalence was about 20% in the city and about 12 or 13% in the state as a whole. And also what was quite interesting and alarming was that there was a gradient. So the antibody positivity amongst the white population in New York was about, I think, 6 or 8%. Among the Latinos, it was like 20, 22%. And amongst the African Americans, it was 28%. And this reflects the socioeconomic disparities. The same has been seen in London and other places. Recently in India, the ICMR put out some data saying that the seroprevalence in about 68 districts, mostly rural areas, was about 0.7%. So as expected, quite low. Some of the cities is probably higher. So that means you have a large majority of the population that's susceptible. So what we tried to do was to focus on the research, the innovation, and the science. And so February itself, early February, we set up a big meeting in Geneva where we had over 400 scientists, doctors, researchers, and some companies as well, developers of vaccines and drugs, attend and discuss for 3 days what the top research priorities were for this virus. And then we formed working groups. So the 9 working groups working on everything from epidemiology to transmission to clinical management, infection prevention and control, therapeutics, vaccines, and very important, we had 2, one on ethics, one on social science. Now, next week on the July 1st and 2nd, we are reconvening all of the 9 working groups to tell us what has been learned, what are the critical achievements and the impact that those have had, and what are the emerging priorities, what are the new gaps in knowledge that we urgently need to address. And of course, we will have a special session on therapeutics, a special session on vaccines, because this is where there's been not only a lot of activity, both private sector, public sector, but obviously is the most closely watched and anticipated. And just to say that we launched the Solidarity trial because WHO normally does not do large, big clinical trials. The reason we did the Solidarity trial, we're still doing it, is a couple of reasons. We noticed that there were many small trials mushrooming all over the place and ultimately resulting in publications which were inconclusive. And therefore it was not serving the purpose. And secondly, we saw that the pandemic is moving from one part of the world to another. So a country that starts a clinical trial like China, for example, basically runs out of patients and cannot complete the trial. This has happened previously in Ebola as well. And thirdly, you want a diverse group of patients to be enrolled and also enrolling fast. So the Solidarity trial, which is looking at 5 different therapeutic, 4 different arms and 1 standard of care, we picked on hydroxychloroquine, lopinavir, ritonavir, with or without interferon beta, and remdesivir, and randomized centrally, very simple enrollment, busy doctors in busy hospitals, just have to fill a very short form that takes 5 minutes. It's all electronic. Patients are randomized, the drugs we supply, and we currently have over 5,000 patients randomized. We've already stopped the hydroxychloroquine arm because it doesn't do anything for hospitalized patients. We are analyzing the lopinavir, ritonavir, and the remdesivir arms, and we'll have some data next week. We want to take a similar approach for vaccines because there are going to be many vaccine candidates coming. We don't know which ones will be successful. There are at least 6 or 7 different platforms, 220 candidates in clinical development. 15 of them are in clinical trials, 3 of them going into phase 3 clinical trials very soon. The AstraZeneca Oxford vaccine, the Moderna vaccine in the US, and a Chinese vaccine. In fact, several Chinese vaccines. There are at least 4 or 5 candidates. And so we want to be able to do studies where there are, again, the right study design is used, a properly conducted trial, the right endpoints are collected, and enough patients in the trial to give us a definitive answer on both efficacy and safety of these vaccines. And I know everyone wants the vaccine as soon as possible. People keep asking, when will you have it? And we say, well, we hope we will have a vaccine because unless you do the phase 3 trials, you can't, be sure of efficacy and safety. What we know about coronavirus immunity, MERS immunity probably lasts for a year or 2 or 3 max. SARS 1, maybe 12 months. For this virus, we don't know how long the neutralizing antibodies are going to last after natural infection and then after immunization. So that's something we have to see. But all of these things are going on, and that's why we launched this accelerator, the ACT Accelerator program, where we brought together many different global agencies and partners, the CEPI, Gavi, UNICEF, Global Fund, the World Bank, and so on, to accelerate, to work with the private sector, work with countries, work with research institutes, and not only accelerate the development of drugs and vaccines and diagnostics, but also make sure that there is equitable access. Because at the end of the day, if you find a drug, if you have a vaccine, it's only available to a few people in high-income countries, it's no good, because this has happened before. This happened during the H1N1 pandemic in 2009. There was very little vaccine left after all the high-income countries had purchased the vaccine from the companies. We want to avoid that situation by having a mechanism a framework which is agreed upon beforehand, which countries agree to, which companies agree to, and having a common pot, a large pot of vaccines, which can then be distributed fairly across the world, because you will start with a few 100 million doses and gradually you may get billions of doses, and then you can vaccinate everyone. But in the beginning, we need to think about whom do we want to protect. We want to protect our healthcare workers, frontline workers, elderly, and then distribute it according to the size of that population in different countries. Maybe Dr. Reddy, if it's fine, I could stop there and take questions. Or if you'd like me to cover some other topics, I could.
I have my board of trustee, Dr. Seema Arora, and the Dr. Uma Maheshwari Jonalagada will be joining. Seema, do you have any questions? Seema, can you unmute Seema, please, Vijaya?
Hi, thank you, Suresh. So, can you hear me now?
Yes,
Can you hear
yes,
me?
go ahead.
Okay.
Yeah.
All right, so Dr. Maheshwari, that was a very informative talk. You did answer some of the questions I had in my mind. And I think the most important question people are asking is about the vaccine, which you did touch base on. Well, are you planning to have different vaccines for different strains? Are you working on, because even if we get one vaccine, it's only going to act on one virus. So what about, how are you handling this situation?
Yeah, thank you. That's a good question. So you know that we have been tracking the virus also since it appeared. And thanks to these big public databases of genetic sequences, there are something like 50,000 genetic sequences, whole genome sequences available today. And by analyzing that, what scientists are seeing is that, yes, there are mutations happening, but none of the mutations has been concerning, in the sense it has not happened in a region of the virus, like the spike protein against which most of the vaccines are being made, which will alter the immune generating properties of that virus. So as of now, the hope is that the virus, vaccines which are targeting the spike protein, and as I mentioned, there are several platforms. There are whole virus inactivated vaccines. There are subunit vaccines where you take only the spike protein, combine it with an adjuvant, and then use it as a vaccine. There are viral vectored vaccines. So you take an adenovirus or a VSV virus and you put the spike protein antigen onto it. That's the Oxford vaccine. It's a chimp adenovirus. And then you have very new platforms, which are RNA viruses and RNA vaccines and DNA vaccines, where you basically take the mRNA and inject it into the person, and then that then generates the protein inside the person's cell and then stimulates the development of antibodies. These are platforms that have never been used in human beings before, both DNA and RNA vaccines, so it would be new. And that's why we have to go through this careful process of trials. So to answer your question, the virus is mutating like all RNA viruses, but it has not been shown to have any impact on either clinical virulence or features as such, as it goes through country by country. Neither as of now, we don't expect the mutation so far. And we have to watch it. Like if it's like influenza and it starts mutating very rapidly, then you would be in a problem generating a vaccine. But as of now, it looks like it's okay. The current strategies should work.
Okay, thank you.
Thank you, Dr. Swaminathan. I have another question. Do you think WHO should prepare a protocol for first response, which all countries should agree to follow? Because a pandemic is a global problem.
Yes, so the WHO does actually have something called the International Health Regulations, which, as I said, talk about both preparation, surveillance, data, and prevention, as well as response. And the issue is that people do not pay attention to that, because if the problem is not there with you, then no government wants to invest money in preparation. So now I think, Bill Gates has referred to it as cycle of panic and neglect. So every time there is a problem like the pandemic of 2009 or the Ebola outbreak of 2014-15, the world starts panicking and says, we must do something, we have to do something. And then it goes back to normal, and then it enters a period of neglect where there's no investments into these things. So I hope that at least now that things will change. And also we want to look at our own international health regulations, and you would have seen there's a lot of debate about WHO should have more powers to really go into countries and inspect and be able to collect more data, more information. We don't have those powers right now. We're an organization that's run by the 194 member states. And so I think there is an appetite now to relook at those rules and regulations and see if those could be further strengthened, so that there's a mechanism by which you could check and by which countries can be given feedback on what they need to do and where there are weaknesses and gaps. But I think the question is a very good question. It's a valid one. It's something I hope that we will see some reform, some movement.
Go ahead, Seema.
Thank you, Dr. Swaminathan. I have a question here regarding convalescent plasma. So does WHO has a stance on convalescent plasma treatment?
So as far as I know, we encourage the use of convalescent plasma in clinical trials. We do not have a clinical recommendation for it as yet. So our guidelines keep on getting updated as the evidence comes in. But as of now, I don't think there is evidence from randomized trials on convalescent plasma.
Okay.
Though there are a lot of reports that it's useful, but what we need to see is the evidence, and we also need to understand at what stage of the disease is it helpful, because we see that in this disease, it goes through these different phases. And at some stages, you might have antivirals and convalescent plasma being effective. At the later stages, probably it requires a completely different approach once patients have entered a phase of hyperinflammation. So it's becoming clear that the same treatment strategy may not be effective at different stages of the disease. And so we really need to look carefully at the way that the clinical studies and clinical trials are being done.
Dr. Swaminathan, thank you so much. So far, it's been phenomenal. One of the questions that comes up regularly is, are there recommendations that the WHO can give, overarching recommendations for countries as precautions when such deadly pandemics break out? Because I think what we've learned from this pandemic is one day one thing is good, the second day something else is better. Could there be some more clarity in the recommendations that are put out?
Yes, of course. And that's what I was talking about earlier, that when you're faced with an unknown or a new pathogen, you can make some guesses. Like at the beginning, the way we predicted that there will be human-to-human transmission is because of what we know from the other coronaviruses. But of course, it's turned out to be very different from SARS or MERS, because those had much less chances of transmission. They mostly had, with very close contact, mostly in the nosocomial settings. So this virus is much more easily transmissible with an R0 of, between 2 and 3. And we've also learned by observing what happens in different countries as they put in place different prevention and control strategies. And that is why the guidance needs to keep getting updated, keep up with the literature. And we are often being asked or put under pressure to come up with guidelines very, very rapidly, because, things come out in the media. And then people say, why hasn't WHO taken a stand on this or that? The way we do it is to be extra careful. We cannot change our guidelines and recommendations every day. And so we have to look at the body of evidence. And if the body of, like, you can take aerosol transmission. You know, there's a big debate now about whether there's aerosol transmission or not. And it's not that we can say 100% that there is or there isn't. Of course there is in certain settings, you know, but the bulk of infection transmission is occurring due to droplets, not due to aerosolization. So from the public health point of view, we need to focus on this. And so sometimes there's also misinterpretation, or people who take extreme view, you know, and say, no, you're completely wrong because what you're saying is not correct. So it's always a balance for us. We also always have to take a public health view of things. And so our guidelines, even when we make them, are of course the scientific evidence, but also we look at the ethics of it, the equity angles of it, the availability of certain products. So we could easily recommend a product, and let's say it's not available at all across the world. Let's say we tell everyone to wear N95 masks. First of all, it's not necessary. I'm not saying that it is necessary. But let's say if it were, it would not be possible for the whole world to be wearing N95 masks. So this is where maybe WHO is a little bit different from some of the other associations which are more focused on clinical and which are more focused within one particular country. So you make recommendations within the United States, within the UK. So then you have a context in which you make it. WHO makes recommendations for the world, and I must say that many countries that ignored WHO recommendations at the beginning of this pandemic actually paid the price.
So actually, my
Yeah.
next question was exactly what you were saying, Dr. Swaminathan. Somebody in the chat asked that question, that why are many people not following WHO recommendations in US, and what can WHO do to change that? So you partially answered that. Can you please elaborate on that?
There's very little we can do actually to change that. Because as I said earlier, we don't have powers. We're not a body with powers of implementation or inspection. We are a recommendatory body. And what countries do with our recommendations is really up to national governments. You know, they can adopt them, they can adapt them, they can ignore them. So most of the time what happens is that it is the developing world that pays a lot of attention to WHO guidelines. I think for the first time now in the pandemic, we're seeing the high-income countries and the developed world also looking at WHO to say, you know, to see what we're saying. But again, I think it boils down really to leadership. Our Director General says that quite often, that it all ultimately comes down to political leadership and the priorities, you know, of the government. And you can see the way different countries have handled it has been quite different. But I hope that everyone is going to learn now that, you know, investing in health, and particularly investing in public health, is really, really essential. And the irony is that if you have a good public health system, then you will never notice it because it will keep you safe. But if you don't have it, then you have outbreaks and you have problems, and then you complain about it. So the success lies in preventing something which you never see and the world never sees and never appreciates.
Thank you, Dr. Swaminathan. This is Suresh again. It's like we are so proud of you. You are at the top of the WHO at this time, where the most challenge is to the healthcare facilities. API considers the 1.2 million global physician community can be harnessed to address and solve the global health problems in general. Does the WHO has any vision to develop a global health force similar to UN peacekeeping force, to which Indian doctors can align their strength?
Yes, that's a very, very good question. And WHO does have such ideas. In fact, we have a network called the Global Outbreak and Response Network, GOAN. And that's a network, I think, of about 10,000 people that's been operating now for about 10 years. And these are doctors, but also public health specialists and others who volunteer themselves to be available in case of emergencies. And they get deployed to different parts of the world when there's an emergency. So during Ebola, for example, we've seen many of the volunteers from the Goan network go and help out. Similarly, we have emergency medical teams. So our Director General has been actually calling upon countries to create emergency medical teams, EMTs, and to make them available. So if country A has, accredited emergency medical team and country B has a problem, you could then call upon this team to go and support. This could be for natural disasters and things, and of course also for infectious disease outbreaks or other health emergencies. So there are mechanisms, but I think it would be really good to strengthen those and expand those as you are saying. And we've also set up now WHO Academy. The academy is to train healthcare workers from around the world, doctors, but also nurses and other kinds of health workers, and through having some training courses. And a big focus of that is going to be on training for the emergency response. So that is in the process of being set up, and by middle of next year, the academy should be up and running.
Seema, you have another question?
Thank you, Dr. Swaminathan. I have another question regarding the role of steroids. That's the talk is on about that a lot, and it's shown that steroids are causing mortality reduction by about 33%, and high level of cortisol in the body is causing more mortality. So what are your thoughts on that?
So the latest evidence we have is from the recovery trial in the UK, which showed that dexamethasone given at 6 milligrams a day, either orally or IV for 10 days, significantly reduced the mortality by over 35% in patients who were on respiratory support, and by about 20% in patients who were on oxygen. It had no impact on patients who did not need any kind of respiratory support or oxygen. So I think it was very clear that which subgroup of patients it works, and it also showed that it has a significant mortality benefit. Now, this study used dexamethasone. There are other studies that have used methylprednisolone or hydrocortisone. And so what we are doing now is a systematic review, a pooled analysis. We've asked for all the data from all the trials that are going on across the world for dexamethasone, for hydroxychloroquine, for lopinavir, ritonavir, and for remdesivir. And we're going to pool all of that, do the analysis, and in the next week or so, we will be able to give a very definitive answer on each of those. Because as you said, steroids could do harm also. So it's important to use them in the right group of patients.
So being an internist and working outpatient, I always hear this question, whether giving Medrol dose back in the early stages of disease, just like we give to asthmatic patients, would that be of any help?
You see, these questions are good questions, but unfortunately, we cannot do guesswork on these. We have to look at the evidence, and we need to do randomized trials. So what we're also going to do next week is to look at what other drugs, what other interventions could be used in trials to look for benefits. And as you are saying, early stage disease, later stage disease, and then very critically ill patients, we still need a series of studies to tell us which of these, and maybe there should be combination of antiviral plus anti-inflammatory at a later stage. There are some inhaled drugs that are being developed, inhaled antivirals, but also inhaled blockers of the ACE inhibitors. So there are some, and then monoclonal antibodies are also going to go into clinical trials next month. We have several of them going into clinical trials. So I think we do have a few promising things which we can look forward to.
Dr. Swaminathan, one of the questions that comes up during our discussions is how does the funding retraction by the United States affect the WHO at this critical time?
So of course it has an impact, but what we feel is it's not the funding, because the funding can be made up, from other sources. It is the collaboration with the United States. We have huge technical collaboration with the CDC, with the NIH. We have a number of CDC secundees in WHO at any point of time. We work together on polio, on many diseases, on immunization. So the downside or the negative effects are going to be on those health programs. So the funding is a relatively minor issue, which can be compensated by others. But the technical work and the impact on health programs cannot be compensated. That's going to be a very, very big, I think, blow to global health.
Suresh, you have another question?
Okay. Dr. Swaminathan, I understand it's getting late for you in Geneva, but I think we should wrap up in another 5-10 minutes. It appears that the governments are this is an interesting question. It's an economics question, but it appears the governments across the world respond concertedly to an economic recession or depression than to a deadly pandemic. Why this paradox?
Pardon, can you repeat that question?
So the governments, they respond right away to economic recession or depression, and but rather than to a deadly pandemic. Is that the response pretty, you think, similar, or is the way it is, I don't know, maybe I'm making it complicated. Just the economy versus healthcare. How are governments balancing those two?
I think what governments do not recognize enough is the fact that the economy is built on good health. And countries that have invested in education and health have seen their economies flourish. And countries which do not ultimately cannot be competitive. So if you take malnutrition, it's a good example of something that affects the cognitive development of young children, and that affects the human capital of that country. You take air pollution, or you can take, diseases due to poor water sanitation. All of these take a toll on health, and the health takes a toll then on economic productivity. So I think we have not been able to make the case that health equals economic productivity. And I don't know if the pandemic will actually result in that realization or not. But until that realization comes, unless countries invest enough in health, as I said, not just in treatment, not in tertiary care, but in prevention and health promotion, we will not see, those countries will not be able to benefit fully from their human capital or become economic superpowers.
Dr. Swaminathan, there was an eye-opening article about administrative leadership in the United States when they looked at hospitals being led by physicians versus healthcare administrators. Outcomes were better in hospitals that were led by physicians, which I think is sort of a obvious to a physician, but not so obvious to a healthcare system. You had talked about political leadership and its role in a pandemic. I think more and more people are relying on healthcare physicians as their leaders because they most often bring unbiased information to the public. Would education of the public brought through by WHO using physicians as the forefront rather than political appointees be a better strategy?
I think education of the public is extremely important, and building a scientific temper among the population is also very important. And we have to start with children, obviously. Physicians could play a very important role in that. And yet you don't see that. You don't see that happening. In most countries, physicians, I think, stick to their business of looking after patients and do not think it is their job to educate people or, you know, to correct misconceptions and so on. And there have been so many misconceptions and rumors and myths that have been floated about this pandemic, about this virus, and also about immunization in general. We've seen the anti-vax movement get into into COVID-19 even before we have a vaccine. So the anti-vaxxers are already campaigning against the vaccine. And I think this needs the kind of thing you were talking about. It needs physician leaders and communities of physicians to really start speaking about not only medical things, but really put into people's minds the right, you know, that in India, you know, we believe in there are a lot of traditional beliefs which are not rational. And those need to be spoken about and corrected. So I think you raise a really important issue, and I'm not sure physicians alone can change that, but they could play an important role because they are a respected profession, respected members of society.
So,
Thank you, Dr. Swamin. Seema, you have another question?
just in continuation to that, I was going to ask that how can WHO help in educating people? Do you have any ideas or anything in mind that would help the public in general education?
So we, in fact, we coined this term called infodemic at the beginning of this. We said side by side with the viral pandemic, you also have an infodemic, and we need to fight against that as well. So we reached out to most of the social media companies, and we're working with all of them. And what we're doing is, if there's somebody who's looking for some information on any health topic, we've asked the social media companies to direct them to a credible source of information. It could be WHO, it could be CDC, it could be one of the credible sources. And that's working well with Facebook, with also with WhatsApp, with Pinterest, and so on. We've tried to expand our, traditionally WHO was basically speaking to member states' ministries of health and public health professionals. That is our constituency. Now we feel we have to speak to the public. So it's a new thing. We've just started it. We have an app, a WHO app for public that people can download. It's in many languages. There is a bot where people can ask questions to WHO. There is also through the WHO Academy, we hope that we can also have some courses for the general public as such. But yes, I think a lot more can be done, and we have started reaching out much more than we used to in the past.
Thank you, Dr. Swaminathan. We have the Vice President-elect, Dr. Ravi Kohli. He has, you would like to pick your brain a little bit? Go ahead.
Yeah, hi, Dr. Swaminathan. Thank you for joining us here and heading this heavy discussion on public health. And I'm a psychiatrist, and I see a lot of propaganda going on in media, especially in social media. Social media is so powerful. There's so many alternative facts, conspiracy theories, and lack of evidence-based thinking, like anecdotal thinking. So I think we need to have a whole new paradigm of education of the physicians. I think we need to start in the curriculum itself, how to deal with this kind of information gap between the science and the popular mythology that is being built. Unfortunately, I'm a technophile, but the social media is becoming a problem. I hope you're reaching out to the major players like Facebook and Twitter. You can influence them to be more responsible ethically for the public health as well as public wealth, public goodness. And I don't see them, they're totally financially capitally driven rather than social capital or human capital driven in their approach. So we need to have a movement of putting them on the target about they have a responsibility. They have a lot of privileges. They have a lot of influence, but I don't see them using it properly. How can we change their mindset?
I think you have raised a question. I don't have an answer for that. We need to think about it collectively. And yeah, people need to recognize their own responsibilities, including the social media companies. I think they are trying to do they've taken some steps to reduce misinformation and so on. But I think, as I was saying earlier, till we have a scientific temper in the population, if people do not learn to question things, if they don't learn to be able to distinguish between something which could be a fact and something which is unreasonable. You can take large parts of the population for a ride, by telling them things which are not rational at all, then I don't think we can make much progress. So I think there's no short-term or shortcut, I think, solutions to this. But people obviously now believe that social media can change behavior in many, many ways. It's incredible how it does that.
Social media is very influential, I know. Actually, there's a study and there's a graph. The social media, smartphone penetration, and self-esteem and happiness in teenagers have decreased proportionally. So social media is doing a lot of harm, unfortunately.
Yeah.
I think we need to train the parents on how to kind of navigate the social media quagmire for their children's well-being. So there are so many factors we need to really focus on.
I agree.
Of course, we cannot give up to the media and let them do whatever they want. We need to have much more impact on how we can manage them.
Yeah, someone in the chat group has asked, why do you think the incidence of the disease is much more in the United States compared to third world countries, including Africa?
I think that answer should be obvious to everyone. I don't think I need to explain that.
Thank you, Dr. Swaminathan. Thank you. I really appreciate taking the time, and we are so proud, immensely proud, that our own countrywoman is being the chief scientist of World Health Organization. Growing up, I always thought I should be a part of WHO. I should work for WHO. Well, hopefully someday. But it's so gratifying to see our own countrywoman at the top. Thank you again, and I let Dr. Seema Arora give a vote of thanks. Please, again, thank you so much for taking your time at these odd hours on a weekend, joining us from Switzerland. Thank you so much. Seema, please.
Thank you, Dr. Reddy.
Thank you, Dr. Swaminathan, for doing this for API. We are very grateful to you. We've been having these webinars for 2 months now, and every time there's something new. This is ongoing. We've had a lot of questions about steroids and all the other things that we asked you. So I'm sure people must have benefited from this talk, and hopefully we'll meet you sometime soon in person. Thank you very much.
Thank you. I look forward to it.
Thank you very much. Thank you.
Goodbye. Bye-bye.
Bye-bye. Namaste.